Hi everyone, welcome back to my YouTube channel, and today we are going to talk about 8 changes in enamel. So let's start our topic with introduction. Dental enamel is the hardest and most mineralized tissue in the human body. It covers the anatomical crown of tooth and functions as a protective layer against mechanical, chemical and thermal forces. Although enamel is acellular and cannot regenerate, it undergoes progressive changes throughout life due to wear, chemical exposure, and alteration in its physical and optical properties. Understanding age-related changes in enamel is important for clinical dentistry, diagnosis, restorative procedures, and preventive strategies. Structural characteristics of enamel. Before discussing age-related modification, it is essential to understand the basic composition of enamel. Basic composition of enamel has mineral content that is about 96 to 98%, and it is primarily hydroxyapatite crystals. It has organic content that is 1 to 2%, and it is protein and trace amount of lipids. It also has water content that is about 2%, and it is present within the interprismatic spaces. Structural organization of enamel. Enamel layers or prisms are arranged in keyhole shapes in enamel structure. There are interprismatic enamel which adds structural integrity. Enamel surface show perikymeta and aprismatic or prism-less enamel in some areas. Age-related changes in enamel. Enamel undergo multiple modification with aging due to mechanical wear, chemical processes, changes in mineral content, and external influences. These changes include morphological changes, optical changes, histological and microstructural changes, mechanical and physical property changes, and chemical changes. First are morphological changes. Morphological changes include surface wear, loss of perikymeta, and reduction in enamel thickness. Surface wear may be because of attrition, abrasion, or erosion. Attrition is continuous mechanical wear from tooth to tooth contact causing flattening of cusp and occlusal surfaces. Abrasion is caused by external mechanical forces such as brushing and habits like biting hard objects that cause surface loss. Erosion is caused by acidic food, gastric acid reflux, or occupational exposure that lead to smooth glazed surfaces. Loss of perikymeta is second morphological change that happens in enamel with age. With age, perikymeta that are horizontal growth line gradually disappear due to surface wear, making the enamel appear smooth and shinier. Third change is reduction in enamel thickness. It is due to cumulative wear processes. Enamel becomes thinner, especially on occlusal and incisal surfaces. Second age-related change is optical changes that include increased translucency and color changes. Increased translucency is with the increase in mineralization and reduction of interprismatic spaces, and enamel becomes more translucent as a result. This translucency contributes to the darker appearance of aged teeth as underlying dentine shows more prominently. Then there are color changes as enamel may appear more yellowish because of thinning of enamel exposes the darker dentine. Static stain from food, beverages, and smoking also accumulate more easily on aged enamel. Third related change is historical and microstructural changes. They include increase in mineral content, decreased porosity, and micro cracks and fissures. Increase in mineral content is aging that promotes ion exchange from saliva that increase fluoride and other minerals within the enamel. Higher mineral content increase enamel brittleness. Second change is decreased porosity. It is because of interprismatic spaces reduces with age that decrease permeability. This reduces diffusion of substances such as bleaching agents and topical fluorides. Third related change is microcracks and fissures as long-term mechanical stress cause formation of microcracks in enamel. These cracks may propagate with occlusal forces contributing to enamel chipping. Fourth age-related change is mechanical and physical property changes. They include increased brittleness and change in hardness. Increased brittleness is although more mineralized, it is because age enamel loses its resilience, and this causes brittleness that increases susceptibility to fracture and chipping. Second age-related change is changes in hardness, as surface hardness may increase due to mineral gain, and subsurface enamel may exhibit reduced elasticity. Fifth change are chemical changes. They include fluoride uptake and mineral exchange. Fluoride uptake. Older enamel contain more fluoride due to prolonged exposure from water, toothpaste, and topical applications. Increased fluoride enhances resistance to caries but contributes to brittleness. Mineral exchange. Prolonged exposure to saliva allows continuous ion exchange, depositing calcium and phosphate ion into enamel. Functional changes in the edge enamel include increased resistance to caries, reduced bonding ability, and increased wear during mastication. Increased resistance to caries. Age-high hypermineralized enamel is less prone to caries initiation than younger enamel. Reduced porosity limits penetration of carcinogenic acids. Second functional change is reduced bonding ability. As restorative procedures such as bonding and etching may be less effective due to lower permeability and higher mineralization. Third change is increased wear during mastication, as thinner and more brittle enamel is more susceptible to occlusal wear, and this can contribute to altered vertical dimensions of occlusion in extreme cases. Clinical importance of age-related changes in enamel. First is the restorative challenges, as it increases brittleness that complicates cavity preparation, and also aging enamel cause adhesive restoration bonding that may be compromised. The second clinical implication is aesthetic concentration, as color changes and translucency increase the need for cosmetic treatment, and whitening may be less effective due to lower enamel permeability. Third clinical implication is risk of crack and fractures, as dentists should be cautioned during scaling, polishing, and restorative procedures. Occlusal guard may be recommended for patients with parafunctional habit. Fourth clinical implication is preventive recommendation, as there is a recommendation of use of fluoride to maintain mineral balance, to minimize abrasive brushing and acidic food exposure, to regular dental checkups to monitor wear. Conclusion of this lecture video. Aging induces significant morphological, optical, mechanical, and chemical changes in enamel. While enamel becomes more mineralized and resistant to caries, it also becomes more brittle and prone to wear and fractures. These changes have important implications for restorative dentistry, preventive care, and aesthetic treatment. Understanding the nature of age-related enamel changes allow clinicians to tailor intervention appropriately to preserve dental function and appearance across the lifespan. And this was all about age changes in enamel. Hopefully you liked the video. If you do, don't forget to like, share, subscribe, and comment. Thank you for watching.